Welcome everyone to the Baltimore County Fire Department EMS Academy. For those who I haven't met, my name is Sean Barinholtz. I am an anesthesia and critical care physician at Hopkins. I'm an active volunteer at Pikesville Volunteer Fire Company, and I have the honor of serving in the medical director's office as one of the associate medical directors of Baltimore County Fire Department. On behalf of Dr. Andy Pollack in the medical director's office, on behalf of the EMS office, Director Shenning, Captain Stewart, Captain Nats, thank you so much for being here. Thanks for what you do every day. Thank you for your dedication to lifelong learning. A big shout out to Ashley Brooks. Ashley is running our live stream tonight. Ashley is going to be sending out a link in the chat function of Zoom. That link, if you click on it, will have an opportunity for you to enter your MIMS number and some other basic information to get your CEUs. So if you want your CEUs, keep an eye out on the chat function sometime during this next hour plus. Ashley will be sending out a link that you can click on to fill out some basic information. So tonight we have Dr. Ryan Felling. Dr. Felling is the director of the Pediatric Stroke Program and an assistant professor of neurology at Johns Hopkins University School of Medicine. The Johns Hopkins Pediatric Stroke Program is a multidisciplinary effort involving neurologists, radiologists, critical care physicians, emergency medicine physicians, neurosurgeons, hematologists, and rehab specialists, aiming to provide a full continuum of care of children with stroke and other cardiovascular or cerebrovascular disorders. The vision of the program is to ensure rapid diagnosis and intervention, aggressive acute care and neuroprotection, and seamless transition to state-of-the-art rehabilitation and longitudinal support. The program at Hopkins is one of the only programs throughout the nation that is fully integrated with Comprehensive Stroke Center. In addition to these clinical efforts, Dr. Felling conducts basic lab research investigating mechanisms by which the immature brain can be repaired and regenerated after injury, with the ultimate goal of developing novel strategies to improve outcomes in children with brain injuries. Dr. Felling, thank you so much for being here, and thanks for being so generous with your time and talent.
All right. Thank you very much. I appreciate the invitation to talk to you guys about what I clearly think is an important topic. So the title of my talk is Stroke Comes in All Sizes. And I've been fortunate enough to be able to give this talk a couple times to emergency medicine professionals at various venues. And I'm happy to give it as many times as possible because I think, you guys as frontline providers are the ones who are really going to be able to help make a difference for these kids. And so, I really like doing these talks because I don't think too many people think about stroke in children. And in fact, going through medical school, I had never even heard of stroke in children. It wasn't until later in my training, almost as I was getting done with my neurology residency, that I sort of learned about pediatric stroke and came to appreciate it as a field. I've always been interested in brain injury. That's where my research interests lie. And pediatric stroke was a nice mesh of those interests that's been really fun to deal with. Let's see here. How do I? There we go. So, whoops. Let's go back to disclosures. I don't really have anything to disclose. No financial disclosures. I will be talking a little bit about treatments that are not FDA approved in children. Those being TPA and mechanical thrombectomy, which I'm sure many of you are somewhat familiar with in the adult stroke world, which is why we always urge the need for time considerations. So the objectives of this talk, this is a whirlwind tour of a lot of things related to pediatric stroke. So we're going to talk about the epidemiology, what kind of kids have stroke, how many kids have stroke, how strokes present so that you can recognize when a stroke is possible in a child, things to consider when planning the pre-hospital care of a child with stroke, and understanding our hospital treatments and how destination choices for children can impact their care. So first of all, what is a stroke? In 1980, it was defined as a rapidly developing clinical sign of focal or global disturbance of cerebral function lasting more than 24 hours or leading to death with no apparent cause other than that of vascular origin. Pretty vague description, but it sufficed for a while. And more recently, they published a much more complicated, I think it was about a 15-page paper defining stroke. And they came to include all these different terms: cerebral infarction, ischemic stroke, silent CNS infarction, stroke not otherwise specified. We have hemorrhagic stroke. And point being that we know that someone can present acutely with a sudden onset of neurologic dysfunction. That can resolve. That's typically what we think of as a TIA, but that person may still end up having a stroke on imaging. You may also have strokes that appear silent. They never give any symptoms. But when we see these things, we really need to think about stroke in terms of risk factors and how these patients need to be managed, because they still have the same risks as someone who presents with an overt stroke. So all those things were sort of encompassed within the definition of stroke a little bit more recently than 1980. In pediatric stroke, we do take a couple other things into consideration. So patient age is important. We basically break pediatric stroke down into two different categories, one being perinatal, and really that consists of 28 weeks gestation to about 28 days of life. And that's an operational definition used more for research studies. When we talk about perinatal stroke in the context of what we usually see, it's a term infant, and it really is the time period right around birth. Childhood stroke, on the other hand, is really anything after that. We also break it down into the type of stroke, with the options being arterial ischemic stroke, cerebral venous sinus thrombosis, and hemorrhagic stroke, which includes non-traumatic causes of intracerebral hemorrhage and subarachnoid hemorrhage. Those are just some images from actual patients over on the right side. You'll see some of these as we go through. This is an MRI of a child with a large right MCA stroke. This is a child with venous sinus thrombosis. It's kind of hard to see here, but you see this this would be one of the veins in the deep part of the brain completely clotted off. And then this is a picture of a subarachnoid hemorrhage in a child. So just like adults, children are at risk for all these sorts of things. And I apologize, I forgot to mention, please feel free to interrupt along the way if you have pertinent questions. I'll try to keep an eye on the chat box, or if you are able to speak, feel free to speak out as well. So in this talk, we're really going to focus on childhood arterial ischemic stroke, because these are the children that you're most likely to encounter, and they're also the ones where we have the most infrastructure put into place to be able to treat them rapidly and diagnose them quickly. So I always like to start off with a case study, and this is an important case because they've been really involved with the Maryland legislature trying to promote stroke awareness for children. There was a 3-year-old girl. She was previously healthy, normal development, and she had presented with recurrent episodes of facial droop and hemiparesis, so face drooping and weak on one side with dysarthria. These were lasting up to 10 minutes. So when someone has this presentation, we typically think of 3 primary things. One is stroke and TIA. That's the most urgent, most concerning thing. That's what I want to impress upon everyone today. So focal abnormalities of sudden onset, they can vary in duration. Obviously, it can be permanent, or they can be fairly brief, from a couple minutes up to several hours. The other big thing, and this is usually what comes to mind first in a child because it's much more common, is seizure. Seizures usually manifest first with tonic or clonic movements, and then weakness can present afterward as a postictal syndrome. We often call it a Todd's paralysis. Migraine, of course, can present with focal abnormalities, and they're typically immediately preceding the development of a moderate to severe headache. So these are kind of the 3 sudden onset, transient neurologic deficits that we see in children. And I always I try to tell my residents and my trainees that when a child presents for the first time with symptoms like this, we need to be thinking stroke TIA first, because that's the emergency. Everything else is, seizures certainly can be an emergency, but not to the extent that a stroke is. Seizures don't really cause any brain damage unless they're going on for a really, really long time. And often 90% of seizures stop on their own. So stroke and TIA is the emergency consideration in this case. So this child was taken to a good hospital, good neurologists, good ED doctors. She was diagnosed with complex partial seizures, and no imaging was done. They presumed that her deficits were due to a postictal period. She was started on anti-seizure medicine, and then she was sent home. She ended up developing a severe skin reaction, had to be treated with significant steroids and Benadryl and different things to resolve that. And then she subsequently presented with similar symptoms. This time they did not resolve. Again, she was diagnosed and initially managed as seizures. Eventually, they did get imaging because her symptoms weren't resolving. This is what they saw. So this is an MRI of the brain. This actually MRI is from a little bit later after she presented several more times. And what we see is this is what we call diffusion-weighted imaging, which I'll describe in a little more detail later. And you see this large bright area over here. This is abnormal, and this is a stroke. This image on the right-hand side is an MR angiogram. So these are the blood vessels that feed the brain. And this is very abnormal. So try to take a snapshot of this in your mind, because I'll show you a normal MRA in a few slides. So this girl had a condition that we call moya-moya disease, which is a significant cause of stroke in children. And it's a progressive occlusion of the carotid arteries. And they can often present with recurrent strokes. But the lessons from this case are stroke is often misdiagnosed in favor of more common mimics, specifically seizures is the most common one that we hear. Early recognition of stroke provides the opportunity to limit brain damage, so that's why time is so important. So let's move on to the epidemiology and talk a little bit about numbers. I always like to show this. So who has a higher risk of stroke? I think it's probably evident that I wouldn't put this up there if the answer was the old guy smoking the cigarette. And we like to say that, so the neonatal period is actually one of the highest risk periods of life for stroke. The reason we see a lot of the, actually, let me see if I need to show a pointer. If I can. Oops. Sorry about that. I'm going to regroup here. Okay. There we go. So if this guy was the one, the reason we see lots of these guys walking around having strokes and not so many of these little babies walking around with strokes is because this child's risk period is very short. It's probably, within a week of the time of birth. We don't know exactly, but we know that the risk of stroke increases as you near term pregnancy, and then it rapidly declines immediately afterwards. And that's all due to blood clotting cascades developing. But if you take sort of the daily risk of stroke and extrapolate that to the short period of time, the daily risk of stroke is actually higher in babies than it is for this gentleman over here. So just it's a mathematical theory of why we need to pay attention to stroke in children. We talked about perinatal stroke, 40 per 100,000 term births. Again, if you take the daily risk, that's the highest risk period of life for stroke. The majority of those are ischemic. These kids you're really not going to see as EMS professionals because they either present right away in the hospital with seizures, so the babies are obviously already there in the hospital, or they don't present until later in life and in a much more subtle onset. So they start to show symptoms of their weakness over a period of weeks to months and not until about halfway through their first year of life for unique reasons that are beyond the scope of this talk. If we think about childhood stroke, so again, anything after the neonatal period, that is much more rare. So 2 to 3 per 100,000 as opposed to 40 per 100,000. This is based on some older data, but still the numbers that we typically go with, and probably it's underestimated. There have been some studies suggesting it could be as high as 13 per 100,000. And that's based on more recent studies where we use MRI much more frequently in children nowadays. But still much less common than perinatal stroke. And so that doesn't seem like a lot, but if you look at the numbers, it's similar to rates of pediatric brain cancer. And I think a lot of people have heard of brain tumors in kids. It draws a lot of attention, a lot of resources and research money. But really, pediatric stroke is probably about the same or more common than pediatric brain cancer. Similar with diseases that are probably better well known, like muscular dystrophy and things like that. So when we think about stroke, often people are thinking about your typical risk factors in adults being hypertension, high blood pressure, diabetes, cholesterol. And those are by and large irrelevant in kids. So the risk factors for stroke in children are much more diverse and much different. Cardiac disease is one of the primary ones. Most of these are congenital heart disease, but certainly acquired heart disease like cardiomyopathies from viral infections and other things that we can see. Cardiac arrests, all the procedures that go along with cardiac disease, these all confer stroke risk to children. The largest category is probably vasculopathy or arteriopathy. So these are abnormalities with the blood vessels themselves, and they can include things like traumatic dissection, so an injury to the blood vessel, or other things like infectious or inflammatory causes are actually quite common. The quintessential example of that is that we don't see much anymore because we immunize against it, but varicella was a very common cause of what we call varicella angiopathy. So an inflammatory constriction of one of the larger blood vessels in the brain that would cause stroke in children. But we do see lots of other kind of focal abnormalities in the blood vessels leading to stroke. And then you can have the more progressive blood vessel abnormalities like moyamoya disease, which I already mentioned. Apologize about that. Tumors, so cancer in general, both because it is hypercoagulable, induces hypercoagulable states, and also because the tumors themselves can create mass effect on the cerebral blood vessels. An important category is cryptogenic. So this is, after we don't find any cause after an extensive workup, about 20% of kids still have what we call cryptogenic stroke. So we can't figure out a reason. And that's important because, we really want to understand what is their recurrence risk. Really, the highest recurrence risk is in this population right here with vasculopathy. Cardiac disease, of course, has some recurrence risk too. If we do an extensive workup and we really don't find any risk factors, then the recurrence risk is fairly low. Not zero, but actually quite significantly low. One question I see in the chat there is, has stroke been linked to SIDS? Not to my knowledge, certainly not in the perinatal period. More seizures are related to SIDS than stroke itself. And CNS infections, so we talked a little bit about the vasculopathy, but also things like bacterial meningitis, tubercular meningitis, commonly cause stroke in children. Thrombophilias, so things like factor V Leiden and other clotting disorders that might make your blood more likely to clot. This represents a pretty small piece of the pie. When we test kids for these disorders, we often find abnormalities, but it's hard to explain a stroke solely based on a thrombophilia because the risk is just kind of incrementally increased over the general population. So usually in a child with thrombophilia, yes, it increases their risk, but they need something else on top of that also to tip them over the edge, like an infection or something else. Sickle cell once was kind of the primary cause of stroke in children, but we've fortunately been lucky enough to have one of the most effective neuroprotective strategies, which is chronic transfusion therapy in sickle cell patients. So now we screen them with transcranial Dopplers to look for the development of abnormal cerebral blood flow. Those get put on transfusion therapy, and that's been incredibly protective against the occurrence of stroke in that population. And then the garbage can category of any other systemic illness. Pretty much if you go through an ICU, all of those kids have a much increased risk of stroke compared to the healthy population. So we're well aware of it in our pediatric ICU, and obviously trying to spread the word to others as well. So one of the myths that I always heard is, okay, well, sure, kids can have stroke, but they're young, their brain is very plastic and can recover really well, so is it really that important? And I would argue that it is. I certainly think that kids do better after their stroke than adults do, but I will show you a little bit of data that suggests that it's certainly not a benign disorder. So consequences of stroke in kids: motor deficits like hemiparesis, weakness on one side of the body, language impairment, intellectual disability, or very commonly more subtle learning impairments, behavioral abnormalities, including mood disorders and attention disorders, and epilepsy are all consequences of stroke in children. This is a study from a group that I've been fortunate enough to do quite a bit of work with, the International Pediatric Stroke Study. So this is a international, but mostly North America, so Canada and the United States, group of people who are interested in pediatric stroke, and we've been kind of collaborating and entering all of our patients into a database so that instead of the 10 patients that I see a year at Johns Hopkins, we get hundreds of patients that we can actually look at and try to learn more about. And this was looking at what were the neurologic consequences after stroke in children. They had about nearly 600 kids at this time. This was quite a while ago, almost a decade ago now. And they found out that at the time they left the hospital, 75% of the kids had some neurologic deficit. That sounds terrible, but it's also not terribly helpful because this could be anything from a mild facial droop to a complete plegia on one side and inability to talk. So they covered the entire severity spectrum. Death, so mortality in pediatric stroke was 3% in this study. Low, but not insignificant. And that's actually been updated and is around that 3 to 5% range. So fortunately, death as a consequence of stroke is much less common in children than it is in adults. But neurologic deficits, I would argue, are actually probably about the same in stroke survivors. So this was a more recent study that we were able to do, and we classified neurologic outcomes as normal, mild, moderate, and severe at 2 years after the stroke occurred, and we divided it by age. And so the light gray obviously is your normal, and then mild, moderate, and the dark black bars are the severe outcomes. And if we think about moderate to severe, the way we define this is they had to have significantly impaired function in at least 2 different domains, meaning sensory motor impairment, cognitive impairment, behavioral impairment, or speech impairment. So they had to have 2 of those affected in a significant way, meaning that they needed assistance on a daily basis. So our definition of moderate and severe was pretty stringent, much more stringent than many other studies have used. And still across age ranges, 20 to 30% of kids after 2 years still had moderate to severe disability after their stroke. So that's pretty significant, and especially when you consider that these kids are now going to be living with that disability throughout their life. So the important part, how do we make the diagnosis of pediatric stroke? Well, first of all, is just being aware that it's a possibility. Everybody says, well, how can you examine a kid and recognize a stroke? It really presents the same way that it does in adults. It's just really being able to think that that's a possibility. And I recall one case when I was a resident. I was actually a senior resident, and the kid came in, and I remember the emergency medicine guy who brought him in said, I think they bypassed the hospital. He said, well, I know strokes don't happen in kids, but this really looks like a stroke to me. And sure enough, he was right. It was a stroke, and it was in a 15-year-old boy. So they got him to our hospital, and fortunately, he actually, he had what we consider a large vessel occlusion that actually recanalized on its own spontaneously, fortunately, because this was back before we were really being aggressive about treatment in kids. But we did make the diagnosis, so he did end up having a stroke. So it certainly can happen, and if you don't take away anything else from this talk, just take away that recognition that it's a possibility. So how do stroke symptoms present? Usually sensory motor deficits, hemiplegia, unilateral sensory deficit or neglect, so numbness. Neglect means they just don't pay attention to one side of the world. Visual field cuts, these are pretty subtle and often difficult for patients to describe what they sense. So it's not, they'll say something's wrong with their eye, but it's actually their brain's interpretation of the eye's information. Gaze preference, so eyes can be forced over to one side, and cranial nerve defects, depending on where the stroke occurs. Speech changes, including aphasia. So aphasia is either lack of ability to produce language or lack of ability to comprehend language, and therefore lack of ability to make any kind of sense of what they're saying. Dysarthria is normal language content, but they can't produce the sound properly, so it's slurred speech. And then also nonspecific symptoms. So particularly for certain types of stroke, they can present very subtly with things like dizziness, vertigo, nausea, vomiting, behavior changes, altered level of consciousness, and seizures. And we'll say a little bit more about seizures in just a moment. So if you remember that snapshot from the beginning of the girl with Moya-Moya disease, this is actually a normal MR angiogram of the brain, probably one of the most beautiful ones you'll ever see. We never get one that's quite this nice. But the circulation to the brain is divided into 2 primary components: the anterior circulation, which are your carotid arteries here and here, and then the posterior circulation, which are your vertebral arteries here and here. The vertebrals join the basilar artery, and the basilar and the carotid arteries all come up to form this circle, which we call the circle of Willis. This is an ingenious evolutionary development and critical for the health of the brain. So we essentially have 4 blood vessels feeding blood to our brain. And because of this circle, if any one of these or 2 of these, or in cases I've even seen 3 of these completely blocked off, there's still the possibility of getting blood flow to all parts of the brain via one vessel because of this circle that provides collateral circulation. So from the circle of Willis, we have branches going off into the large parts of the hemisphere, so the middle cerebral artery, the anterior cerebral artery, and then, which is a little difficult to see, this posterior cerebral artery, which is actually projecting in and out of the screen here. And the reason it's important to understand these is because the blood vessels dictate what symptoms will present when one of those blood vessels is blocked. So this is just a diagram of those blood vessel territories. So in beige, you have the MCA territory. In blue, you have the ACA, or the anterior cerebral artery territory. Red is the posterior cerebral artery territory. And then over here in the purple and green, that would be our vertebrobasilar system. We'll go through each of those to let you know how strokes present when one of those blood vessels is blocked. So the MCA is the classic stroke syndrome. This is what the FAST screen points out, and this is what the vast majority of strokes are going to present with. So contralateral, meaning opposite side of the, so our left side of the brain controls the right side of the body and vice versa. So you get a contralateral hemiparesis, so weakness and sensory deficit, and it affects the face and the arm more than the leg. And I don't have a picture of this, but in textbooks there's this classic, it's called the homunculus. So there are these diagrams of this guy who's laying over top of the brain, his legs are dangling down here, and his body's here, his face and his arm are coming down here. And that's because that's the somatotopic organization of the cortex. So each part of the body is represented in specific parts of the cortex. And so the leg is up here in the anterior cerebral artery territory. The face and the arm and the hand are represented down here in the middle cerebral artery territory. And so when that's affected, we get weakness of the face and the arm more so than the leg. Depending on which hemisphere is involved, so our dominant hemisphere, we get aphasia and language deficits. If our non-dominant hemisphere, or typically the right hemisphere, is affected, we get neglect of one side of the world, or visuospatial problems. And we can also get visual field cuts because the nerve pathways going from the eyes back to the occipital cortex cut through the MCA territory. And you can get gaze preference. So there's fields in the front part of the MCA territory that sort of direct eye movement a little bit. And the eyes can be pointing towards the stroke. So you lose some of that input and the eyes are deviated one way. The anterior cerebral artery similarly gives you a contralateral hemiparesis, but this time predominantly involving the leg more so than the face and the arm. And you can also have a lot of behavioral alterations because the ACA covers the frontal lobe. So problems with executive function. There's a condition called abulia where patients are just very, very slow to respond. So you ask them a question, they will just stare at you and not respond. And then literally 2 minutes later, they'll give you the correct answer to whatever you said, which is kind of maddening when you're trying to examine them in the hospital, but just recognizing that's a possibility. Posterior cerebral artery. So these are tough to pick up often because really the biggest thing that's affected is your occipital cortex, which is a visual hemianopsia. So both eyes can't see one side of the world. And patients, they have trouble explaining it. They often don't notice until they realize that they're kind of bumping into things on one side because their visual fields are constricted on that side. If you get involvement of the thalamus, you can also have hemiparesis. You can almost mimic an MCA syndrome. And you can have memory impairment because the hippocampus and the area that we call the middle temporal lobe are involved. The vertebrobasilar system, so this covers the brainstem and the cerebellum, and these are the frightening ones to us because they can be very subtle. So it's not a classic acute onset like your typical stroke. The basilar artery has many, many little tiny feeding vessels that kind of branch off of it and feed the brainstem, which obviously is a critical part of the brain. That's where all the pathways go through from the big cortex or the thinking part down through the brainstem and out to the body. So when you get a blood clot in the basilar artery, you can start picking off these little tiny feeding vessels, and you just get these very subtle accumulation of problems over time. Often they'll have nausea, vomiting, vertigo. You can have cranial nerve problems, so you can get some facial droop and some eye movement abnormalities. But again, it doesn't have that classic stroke appearance, so often these get missed and it takes a little while for the diagnosis to be made. But if you occlude the basilar artery completely, then you can infarct the brainstem, which is very severe in a high-risk situation. So we're always alert for this, and we're always trying to make sure we can pick it up if a patient presents with it. So I mentioned I wanted to talk a little bit about seizures and pediatric stroke. In adults, it's interesting. If you look at sort of criteria for giving TPA, which is the clot-busting medicine that we give in stroke, seizures are almost a contraindication because it's so rare for a stroke to present as a seizure in adults. In kids, that's not the case, and in fact, it's the presenting symptom in almost 20% of cases of stroke in children. Even more common in perinatal stroke, where it's often the only sign that neonates have. Typically, the seizures are focal, so one part of the body that corresponds to a subsequent deficit. So the patient is seizing, they're having clonic movements of their arm, and then afterwards they have an arm weakness and facial droop on that side. Most often, if a diagnosis gets missed in favor of something else, it's that it was determined to be a seizure and a postictal Todd's paralysis. So I try to tell people that in a child who has no history of epilepsy and no history of seizures, if they present with a focal seizure and a subsequent paralysis, even if it resolves, we should treat that as a stroke until proven otherwise. Because again, the seizure itself, while it's scary, it's not an emergency to the degree that a stroke is. So case study number 2. So this was another patient that I saw when I was a resident. This was a 1-year-old boy who was being carried down the stairs by, I forget, a grandparent maybe, accidentally dropped him. He kind of fell, hit his head on the steps. He did not lose consciousness. He was crying right away. He was taken to the emergency room. They did a CT scan, which was reported as negative, and he was sent home. He continued to be irritable and crying throughout the day. Finally, his parents took him back to the hospital later in the evening. And this time they got another CT scan, and this time it wasn't quite normal. So this was the subsequent CT here. And you see this area that I've circled is a little bit darker than the rest of the brain over here. And that's an evolving infarct on that side. And if we go back to the initial CT scan, you also see this little tiny bright dot right in the sulcus. And that's what we call a hyperdense MCA sign. So this was a clot in the middle cerebral artery there. And if people had done a really good exam, I would imagine that they probably would have noticed this kid was weak on one side. Of course, that's hard in a screaming, angry 1-year-old. But again, recognition of the risk factors, we would have been able to probably pick that up. So he came back with this evolving infarct at this time. Eventually, he got an MRI. So this is what we call diffusion-weighted imaging. This bright area here is his stroke. The fact that it's dark on a corresponding image called the ADC map means that this is an acute stroke. And by acute, the best timing that we can give you based on imaging is this happened sometime in the past week, essentially. The appearance of this on this type of imaging changes over the first 7 to 10 days. And eventually, these kind of images will flip-flop. It'll be bright on the ADC map and dark on the diffusion-weighted image. And this was his perfusion scan, so blood flow scan. And we can see the area of the stroke in this red area. He also has a perfusion deficit right here. And we'll talk a little bit more about the meaning of that, which is critically important in adult stroke and becoming more and more important in pediatric stroke as well. This was his MRA. So again, if you just think about symmetry, looking from right to left, we're obviously missing an important blood vessel right here. We're missing his right MCA. And we're missing his right carotid artery. So you see the left carotid here and the left MCA, and we're missing that whole structure on the other side. This is a picture of his neck. So you see this blood vessel coming up. This is the carotid artery on the right side and has this nice tapered appearance. So this is a carotid dissection. So an injury to the carotid artery. I won't say it's very common after an injury, but we certainly see it in both children and adults where you get a little bit of a tear in the blood vessel and that occludes it and causes a subsequent stroke. So he ultimately developed a full MCA and ACA infarction. He required a decompressive hemicraniectomy, so they had to open his skull up because of the brain swelling. And he survived, but he has a significant hemiplegia and significant neurologic disability now. He's now 6 years old. I actually just saw him in clinic the other day, and he's doing well. So he can't really move his left side at all. He definitely has some cognitive and behavioral impairment, but he's in school. He's a pleasant, happy kid, does a lot of fun things. So, again, if an adult who has that sort of stroke is at risk of mortality, if not very, very significant disability, but this kid is significantly affected, but still able to walk and move around, go to school, and have a pretty good quality of life. So let's talk about acute management. And this is really why the rapid recognition of stroke is so important. So time is of the essence, but unfortunately diagnostic delays are common in children. Again, we talked about mainly because people just don't think about stroke being a possibility. This was a study back in 2002 that looked at the average time to diagnosis of stroke in children, and they found that the average time was 35.7 hours. The median, so the dead center of that was actually 12 hours, and you can see the range 0.1 to 300 hours. What I thought was one glimmer of hope is about 30% were diagnosed within 6 hours. Just to give you some perspective on these time windows, so the time window for giving TPA is 3 to 4.5 hours by guidelines. The time window for thrombectomy in the absence of some advanced imaging and certain criteria is generally thought of as about 6 hours. So only about 30% were being diagnosed within what we would consider a standard treatment window. So that really needs to improve. And the reasons were multifactorial. So lot of delay in presentation, so 28 hours before their first encounter with a healthcare provider. Similar, this is parents not recognizing stroke in children. And then once they got to the hospital, there's still a 7-hour delay until initial imaging was done. And usually that was a CT scan, which may or may not show the stroke, depending on when the time was. So why is time so important? This was a mathematical exercise that one of the stroke neurologists out in Texas did, and he sort of calculated how many neurons are lost during your typical stroke. And the one that I think of is almost 2 million neurons per minute are lost during a stroke. And this isn't quite accurate because you don't sort of continuously lose 2 million neurons every single minute of ischemia. We know that you sort of lose a big core of the neurons right away, and then there's a surrounding area that's at risk that is kind of slowly dying over time. But nonetheless, that, you know, everybody wants to keep as many neurons as we can, so the thought of losing 2 million neurons in a minute is frightening to a lot of people. And so that just stresses the need that we need to be fast at making the diagnosis of stroke and treating it. The American Heart Association has recognized this importance, so they came out with this ad campaign. We've all heard time is brain, and this adage was modified a little bit to say time is brain at any age, really prompting quick recognition and early diagnosis. So there's much more awareness nowadays of pediatric stroke, but, you know, I still get countless calls saying, you know, it can't be a stroke because this is a child, or this, that, and the other thing. So nonetheless, very important. And why is it important? So we know that TPA, this is a study from adults looking at the American Heart Association registry, and they look at the odds of a good outcome based on the time from presentation to treatment. And this is really where our time window comes from. So the odds of a good outcome, so you're twice as likely, more than twice as likely to have a good outcome if you were treated within 60 minutes of your symptom onset. The odds of a good outcome decreased gradually over time until you got out to this point of about 4.5 hours, where this confidence interval, so the statistical possibility of where this could be, actually crosses over, and TPA becomes more risky than it is beneficial. So that's really where our 4.5-hour window comes from. And it's always important to remember that, you know, this isn't a window in the sense of, hey, as long as we get the treatment within 4.5 hours, we're good. You see that continuous decline over time. So we want to be as early as possible and as fast as possible, giving TPA when it's appropriate. So you heard a little bit of my introduction. I do a lot of animal research, so I do love kind of the basic science studies. And this was a study from way back when that really gave us the basis for why we can do things like TPA and mechanical thrombectomy. This was up in Boston, and they had some monkeys where they decreased cerebral blood flow by various degrees. They were able to induce a paralysis, so it looked like the monkey was having a stroke. They realized that, depending on the degree that they reduced that blood flow or the time that they left it reduced, they could recover that function. So the monkey would be paralyzed, but then they would be restored without any permanent injury. If the blood flow was reduced severely or more mildly, but really for a really long time, then they would develop infarction, and that disability would be permanent. So that was an old animal study, and now that's really the basis of what we do in the emergency room. So we can look at this at MRI nowadays. So this is an MRI that is your diffusion-weighted imaging that we talked about. This is an area that's just color-coded purple here. This is what we consider our core infarct. And then we can use a corresponding blood flow MRI or perfusion study to look at the, quote, at-risk territory, so the ischemic penumbra. So this area outlined in green is not yet infarcted, but is at risk of infarcting if we don't restore blood to it very quickly. So this is really the basis of our reperfusion therapies, including TPA and mechanical thrombectomy. So moving on to pediatric stroke, obviously this has transformed the care of adult stroke, and everybody wanted to say, well, hey, can we do better in pediatrics in treating kids and improving their outcome? So this was a study that came out of, there was a trial that tried to look at the safety and efficacy of TPA in children. And this was back in 2011 to 2012 that it started. And unfortunately, the trial was stopped early because they just really weren't getting any enrollments. And so after the study, they were able to figure out, why did that really not work out? They figured out what did they need to really be able to diagnose stroke quickly and to be able to theoretically treat kids with TPA if they showed up with a stroke. And they came up with the idea that they needed at least 3 subspecialists who were dedicated to stroke. They needed a pediatric stroke neurologist really to act as a champion, and MRI stroke availability 24/7, a stroke team, sedated MRI capabilities, ED order sets, ICU order sets, all these things. And in the ramp up to the study over almost a decade, this just shows the percentage of centers that actually had these capabilities. And really, it wasn't until the study was well underway that all of them felt fully capable of being able to do this. So that's probably why they didn't succeed very well. We've since gone on treating TPA, and I'll show you a little bit of data about that, but it's really, pediatric stroke is rare, and it takes a lot of people to be able to effectively implement a rapid diagnosis system and a rapid treatment system. So you really need people who are championing that cause continuously and trying to keep people on their toes. In Maryland, we have 2 centers that are really could be considered primary stroke centers. So Johns Hopkins and also Children's National Medical Center has the capability to give TPA. Mechanical thrombectomy, we are really primarily doing at Johns Hopkins. Children's National can't do it right now, although they can send patients to us or to nearby stroke centers for that as well. So this was the alert system that I set up at Johns Hopkins, the pediatric BAT team or brain attack team. And really, it's just an algorithm that we've sent out to different parts of the hospital to say, when do you activate this? Is there acute onset of a focal neurologic deficit, weakness, numbness, speech, loss of vision, loss of balance, new focal seizure? Was the patient last seen normal within 12 hours? And it goes through a flow sheet here, and you can activate this PEDS BAT from anywhere in the hospital, and you get a rapid response from the neurologist who's on call to examine the patient right away and decide, is this a patient with a possible stroke? And if so, is that a patient who is a potential candidate for emergent treatment? So we've done some data analysis over the first 3 years that was activated, from 2014 to 2017. And this was the breakdown of how patients were presenting to our hospital. So in contrast to adults who are almost always presenting by EMS, because people know, the fast face, arm, speech, time to call 911, that's been a great ad campaign so people realize how important it is. Most of the patients, or not most, but a large chunk are presenting by parent transport. So parents are just bringing them into the hospital. Transfers from other hospitals and EMS, so a chunk of these will be by EMS transport. These are ones who are directly transported to us by EMS. And then, of course, a chunk of kids who were in the hospital already at the time they had their stroke. So we did a little bit more analysis and looked at, okay, where was the pediatric stroke alert or the PEDS BAT alert being activated? Vast majority in the ED, so almost 70%. Another big chunk in the PICU, also on our floor. But then look at all the other breakdowns. So we've had EMS people call in and activate our BAT team. We've had the PICU transport team getting a patient from somewhere else. We've had patients in clinic being able to activate it. We've had outside hospitals calling in and activating this. And it's important because it alerts us ahead of time, and it has somebody ready to sort of examine the patient quickly and make the diagnosis as fast as possible. This is the breakdown of 120 activations, what the diagnosis ended up being. So 15% ended up being ischemic stroke or TIA, 2% being hemorrhagic stroke, and 3% being some other cerebrovascular condition. So it was an arteriovenous malformation that did not rupture, or an aneurysm, or something like that. So what it comes down to is about 20% were a stroke-related diagnosis. Seizures, another 20%. CNS infections are an important category, 4%. And then this other is probably non-specific things. So these are a lot of the ICU patients who were sedated or encephalopathic or something else that was, not really relevant. But 15% plus 20% seizures, so that's 40% between the stroke diagnoses and the seizures, another 4% CNS infections. These are what we would consider stroke or actionable mimics. So something that wasn't a stroke necessarily, but benefited probably from an urgent neurologic assessment. The migraines and the functional, so 20% were your patients who were non-emergent stroke mimics. And then some of the others that we didn't get a clear diagnosis on. But we find that to be a pretty acceptable rate. We want this to be an overly sensitive system because what we don't want is we don't want to miss a stroke. we're happy. It's not hard for us to quickly evaluate a patient and say, this is definitely not a stroke. It's something that we can address a little more gradually. And then, so we looked at the times in our system, and we compared it to our adult system as well. You can obviously see the numbers here. So pediatric activations versus the adults, we have many, many, many more adult activations over the same time period, which is not unexpected. But the important things are the time to neurology evaluation. So our median times for inpatients are 26 minutes from symptom onset, and the median times for outpatient presentations are 71 minutes. So that's actually, to us, really good. So half of these patients are being evaluated, just over an hour after their symptom onset. So I'll take that. That's a huge improvement over those diagnostic delays that we talked about earlier. And certainly puts us well within the window of being able to treat patients if they're appropriate. So how do we treat patients in patients with stroke? First of all, of course, ABCs, always airway, breathing, circulation. This is something that you can pay attention to in the pre-hospital phase. Oxygen, we want to maintain normoxemia. There's always some concern that excessive oxygen could be detrimental too. So we want to use supplemental oxygen judiciously if their oxygen level is low. So less than 92% is kind of the general guideline that we would go by. But probably would err on the side of giving them oxygen as opposed to letting them be hypoxic. Perfusion, so we want to allow permissive hypertension. This can be done with fluids and positioning. You can lie the patient down supine. That obviously helps push blood flow up to the brain. We want to maintain normal glucose and specifically treating hypoglycemia. Be aggressive about treating seizures and fevers because that will help to reduce the metabolic demand and reduce expansion of the injury. And then recanalization treatments. So in children, they are unproven and they are unapproved, but we are using them and others are as well. So this is the group that I work with who was initially part of that trial that unfortunately didn't get continued funding, but we have continued to give TPA over the intervening years. And so more recently, we were able to analyze some of the data of 24 patients who received TPA by adult guidelines. So that means they were treated within 4.5 hours using the standard adult weight-based dose. And none of those patients had a symptomatic intracranial bleed. That's the most feared complication of TPA. 24 patients is not a whole lot, so they had to do some fancy statistics in the study. And what they ultimately determined is that there's probably more than a 90% chance that the true risk is below 10%, probably at least better than a 70% risk chance that the true risk is below 5% for symptomatic bleeding. The number that we quote for adults is about 6%. So kind of what we're getting the picture of is that TPA is probably just as safe in children as it is in adults. The only concern is that you have a much higher risk of treating a mimic in children than you do in adults, but nonetheless, it seems to be safe. Endovascular thrombectomy, so again, going in with devices and pulling the blood clots out. People think of kids as, can we really do that in kids? This was a study that just looked at the diameters of the blood vessels, the cerebral blood vessels in children. And this is kind of what we call the rule of 5. So by 5 years of age, your blood vessels are actually the equivalent of adult size in the brain. So any devices that they use in adults are able to be used in children over 5. And actually, even down to newborns, the devices themselves fit in there. There's just a higher risk of potential injury to the blood vessel, or what we call vasospasm. And that can be affected in the leg where they go into the blood vessel or up in the brain itself. Above 5, really, we consider you could be treated as an adult. Below 5 needs to be considered. This was a study that looked at several different age groups, so 110 patients. They looked at basically outcome after being treated. This is not a controlled study, so there could be some publication bias here. But what they found is that TICI score 2B or 3, this is just a score to determine the adequacy of recanalization. So how much did you open the blood vessel up? 2B or 3 is considered an excellent result. So you see 12 out of 16 in 0 to 4 years of age, 22 out of 24 in 5 to 9, 27 out of 31, 10 to 14, and 22 out of 24 in 15 to 16. So those are really good rates. NIHSS score, so your NIH stroke scale score, 0 to 1, which obviously would be very good, or reduced by more than 8 points. You can see almost more than half of patients had good outcomes based on that after mechanical thrombectomy. So again, take it with a grain of salt because they don't have any comparison groups. Many of these kids may have done very well without treatment too. We just don't know for sure. But very few kids had any complications. So again, data emerging that this is both safe and possibly effective. This was another study out of mostly Germany and Austria, but also included 2 US centers. And so these show results. So really good outcomes over here on the left, really bad outcomes over here on the right. So this is the modified Rankin scale. 0 in the blue is normal, 6 is death, with a gradation in between of severity in terms of their functional outcome. So all these little cool named studies, ESCAPE, Extend-IA, Mr. Clean, Revascat, HISTE, these were the seminal studies in adults that showed that mechanical thrombectomy can really improve outcomes. And so they did a retrospective study. So they went through, forget how many patients did I put it on here, 73 children that have received mechanical thrombectomy, median age, so a range of under 1 year up to 18 years of age. And they looked at the outcomes, and that's these 2 here. So outcome at discharge and outcome at 180 days after discharge. And if you look at their functional outcome, better than all the adult studies that were done. So again, suggests that mechanical thrombectomy is safe, and again, not controlled, so we can't definitively say that it's effective, but the outcomes in children are good after this procedure, even better than the outcomes in adults, which really transformed the way we treat adults. So encouraging data nonetheless, so to support our approach. So what are our practices at Johns Hopkins? For IV TPA, we will treat within 4.5 hours of their last known normal. We use a standard adult weight-based dose. We then monitor them intensively in the ICU overnight. We have a couple of relative contraindications that are unique to pediatrics. We talked about moyamoya disease and sickle cell disease, because both of those have a relative have a relatively increased risk of bleeding. So we include those as contraindications in children, although interestingly, they're not defined contraindications in adults. But considering that this is not an approved treatment in kids, we want to be a little bit extra cautious. Endovascular thrombectomy, we really do it similar to our adult practices. So we do not have any strict lower age cutoff. The youngest child that we did a thrombectomy in was a 9-month-old who was on ECMO actually, had a occlusion of their basilar artery, and the patient had a bad outcome. Regardless, they had a pretty poor prognosis no matter what. But technically, we were able to go in and actually open up the basilar artery with relative ease. We will do this for large vessel occlusions within 6 hours of last known normal. And according with the most recent data, we will also extend that window based on advanced imaging. So looking at that core infarct versus the at-risk territory characteristics. So just to wrap up a little bit with some other cases. So this was a 9-year-old girl who presented with right face and arm weakness, numbness, and slurred speech. So, again, just like an adult would present, her symptoms started when she was at school at about 4:30 in the afternoon. At that time, she fell to her knees, had headache and blurry vision as well. They called EMS. She presented as a Bravo trauma in the ER. They got a CT scan that was negative. Because they found her on the ground, they assumed that she had fallen, and that's why she sort of came in as a trauma activation. Eventually, after they realized that there was no trauma, somebody was able to call our PEDS BAT team. At that time, her NIH stroke scale was 6. So again, the NIH stroke scale is a 0 to 42 scale. 6 is significant deficit, so we would say low would be under 4. We took her for a hyperacute MRI, so this means an urgent MRI with a limited number of sequences. And this was the imaging that we got. So this is our diffusion-weighted imaging, again, that we've seen a couple of times now. And it's pretty subtle, but if you look right here, you see this little strip of bright signal that you don't see on the opposite side. Again, here's our ADC map. It's correspondingly dark there, so that is our acute infarct. And interestingly, she had this blood flow abnormality that involved the entire territory of her left hemisphere. And when she came out of the scan, her NIH stroke scale had worsened from a 6 to a 13. So I think we actually caught her in the process of her vessel occluding. And then we started seeing some of that blood flow abnormality. During MRI, her NIH stroke scale worsened to 12. So we discussed with her family, and we transferred her to the PICU for IV TPA. This actually ended up being a very easy conversation because the little girl's grandfather had recently had a stroke and was treated with TPA and had a really good outcome. So her parents were familiar with it and quickly agreed to do that, despite the the unknowns that we have to say we don't know a lot about this in children yet. So her infarct remained stable to what we saw in that MRI, and clinically she continued to fluctuate kind of around that NIH stroke scale of 6, but then showed impressive recovery over the next couple of weeks. And that's her there. So when she was in the hospital, her right arm, which she's holding up there after going to see Wonder Woman, was completely plegic and she was unable to move it at all. This was about 4 weeks afterwards, after some rehab, and she was already able to lift it up above her head. And so she's continued to have weakness on that side, but she's a fun little girl and has had a really nice outcome. And fortunately, we were able to treat her. Another study, another case study that came in. So this was a 14-year-old boy who presented with the acute onset of dizziness, right face and arm and leg numbness, beginning in the setting of an argument with his father. So he was at home, they were arguing, and he started suddenly just complaining of these symptoms, which were somewhat vague, but there was a clear time of onset at 7 p.m. His dad wasn't really sure what was going on. He thought it was a panic attack, but he called 911 and ambulance transported him to GBMC. In the PZD, they actually sort of recognized the acute onset and thought about a stroke, so they consulted their adult ED, which obviously has a lot more experience with stroke. And then they called our adult stroke service, our brain attack team, because we actually have a contract with GBMC where we cover their acute stroke presentations. And so they called our stroke system at 8:32. This is a picture of his, sorry, this didn't turn out very well, but this is a CT angiogram that was obtained there. And this is looking at his head from a side view, so a sagittal view. And what I have circled here is his basilar artery coming up and an acute occlusion of his basilar artery right here. He also had this funny other abnormality. So usually this should look like a nice straight blood vessel that I'm pointing to here. But he has this very irregular, almost pouch look to it, kind of an aneurysmal dilation of this. So we brought him over for presumed possible mechanical thrombectomy, given his basilar artery occlusion. But given these findings, we were actually concerned about a connective tissue disorder, so a fragility of the vessels. And in that case, you actually might not want to do anything by sticking devices in there and pulling them through the blood vessels. We looked at him. He was actually getting really good blood flow retrograde. So again, around that circle of Willis, the flow was coming from his carotid arteries backwards down towards his brainstem. So there's only a tiny little part of his brainstem that was blocked off and not getting good flow. So we decided not to give TPA because there was a possible dissection or that irregularity. And then he was evaluated at 9:58, still had a NIH stroke scale of 6. This is that abnormal blood flow, but again, this is the basilar artery, and you see this occlusion right here on an angiogram. And we decided not to do anything. This ended up being his stroke. So a bright signal right here in what we call the midbrain. He underwent really intensive rehabilitation and really struggled because this kid was a really, really competitive high-level soccer player. And he had pretty significant weakness of his right leg. I'm happy to say that he's not back to playing soccer, obviously concerns for recurrent stroke and things like that, but I just got a video of him pretty recently kicking a 40-yard field goal with his previously weak right leg, and so he's back in school doing really well. This was a good example of a potential intervention that we decided not to do, and I think ended up being the right call as well. So 6-month outcome, his modified Rankin scale is 2, his pediatric stroke outcome is a 1, which is mild deficit, so again, a really good outcome. So summary and take-home points, stroke can occur in children. It's one of the most time-sensitive neurologic diagnoses we can make. We have key neuroprotective treatments that can be initiated just based on suspicion. So again, the positioning, trying to maintain blood flow, giving oxygen when needed. We do have pediatric stroke centers that can provide similar therapies to adult stroke centers. And the rapid recognition of stroke in children allows for that possibility to provide acute intervention, and it may improve outcomes. We really think that it does, but we're still waiting for the research that definitively says that it does. So I would encourage you guys to keep this in your mind when you see someone presenting with a possible stroke. Just remember that it can present in kids, and think about that when you are bringing them in. So that's all I've got. I'm happy to take any questions either verbally or through chat. If anybody
Dr.
has
Felling, thank you so much. That was great. What a ton of great information for our providers. Thanks so much.
You're welcome.
So yeah, so I hope everyone sees the chat. Feel free to send in some questions. I had a couple of questions while we're waiting for others to chime in. So one thing you said was that a lot of these TPA trials in kids are not controlled.
Correct.
Do you think that there's equipoise in the community that you could even do a randomized trial? So for other providers on the line, equipoise means that we're not sure what's good or what's bad. So it's totally ethical to conduct a study where some people get randomized to a group that gets an intervention versus another group gets randomized to an intervention where they may not get some invasive procedure, for example, but rather let's just see how they do. So to do a randomized trial, we need to be the community needs to be in equipoise. So my question is, yeah, do you think?
So that's a great question, and I think that totally depends on who you talk to. I think the stroke people are pretty well convinced that we think it's going to be beneficial and that it's safe. I'm not sure that everybody does. I've certainly talked to some hematologists, so some blood doctors who are a little bit concerned about, the blood clotting system, especially in younger children, isn't quite the same as older children and adults. So not knowing if that dose of TPA is right. I think the pragmatic point is that I don't think we'll ever be able to perform that definitive study because of the rarity of stroke. To be able to get the numbers of children that we would need, I think, the first trial that we attempted, I think just shows that even if we have lots of centers that are able to do it, it's going to be an incredible challenge to get the numbers of children that we would need to really come up with a definitive answer. So I think we do have to do these kind of midway studies that aren't perfect, but give us some information and then really rely on our clinical impressions.
Another question I had is, the adult population, the guidance for our providers are now for large vessel occlusions are now up to 23, 24 hours after last known well time. I noticed the kids were still at less than 6 hours. Do you think that will migrate?
Well, so that I've actually updated that algorithm that I showed actually said less than 12, but we've updated that to 24 hours now.
Oh, great.
And really, when you think about it, that's kind of the guideline is 24 hours based on the studies that we did. But what we're really trying to do is we're trying to abandon time as a measure because time is really an arbitrary measurement of what's going on in the brain. And we're now realizing that with our advanced imaging capabilities, we can get a much better picture of what's going on in the brain rather than sort of arbitrarily assigning a time to it. So it's still about 24 hours is kind of what we use as a guideline in children as well.
I don't remember those numbers in the ALS update.
Sorry, what's that?
In the ALS update, remember I mentioned that I came to you through the MIMS ALS statewide update for EMS?
Yes.
And pediatric stroke became, more of an emphasis that, this happens in kids and, there needs to be, recognition and transportation. Other providers can correct me or I can pull it up, but I don't remember the time frames being similar to what we're sharing now. But I can.
We'll have to correct that because it should be right. I think, from pre-hospital perspective, I think anything within 24 hours really should be treated as if it looks like a stroke, it should be treated as an acute stroke.
And again, because there's only really one stroke center for kids, that's a big implication for our providers if we're going to be.
And I think, destination choice is certainly beyond my, I know Jen Anders is highly involved in that, but I will say that almost any time a patient goes to an outside hospital, that almost eliminates them from TPA consideration, because by the time we get them to our center, they're going to be outside of the TPA window. Mechanical thrombectomy with advanced imaging, we have a much longer window now, but it certainly is a limitation when we have to transport someone between multiple hospitals.
Yeah, for sure. Anything else, you guys? Any questions? Feel free to put them in the chat. Also, Ashley has sent around a couple of times now the sign-in sheet, the link for the sign-in sheet. If you want your sheet to use, click on that link in the chat function and fill out some basic information. It should take you about 10 seconds to complete that form. Any other questions for Dr. Felling? It says in case study number 4, as a guest, the 14-year-old stroke actually resulted from agitation around arguing with his dad.
No, so I think that was a coincidence. He has, we still don't exactly know why he had a stroke, but I think he had a blood clot. I think the argument around his dad, I think, was a red herring, because I don't really know how to explain that as having any contribution to it.
Oh, but wait, you're 14-year-old. Your kids aren't 14 yet.
No.
There any
Let's see a couple of things. I'm trying to get to the. Somebody asked for contact information. Unfortunately, I can't get my cursor over to the chat to type it in. But please feel free to provide my contact information to everyone if they want to reach out.
Yeah.
And I see something. Is there any role experimentally for? I can't see the rest of that, and I can't move my chat box. Is anybody able to read that?
Your cooling.
Cooling.
Event. It says.
Yeah, so cooling, obviously we do for neonates with hypoxic ischemic injury. There's a lot of interest in cooling for stroke as well. In adults, it really has not panned out as being effective, and in fact, it's if anything, it's been potentially more dangerous. I think because of one of the things that hypothermia can do is induce coagulopathies and cause more problems. In kids, I think still is a potential to be explored. In neonates, for example, who we suspect have HIE, obviously we cool them before we get any imaging. So we've had quite a few neonates who we've cooled for suspected HIE and then found out that they ended up having a stroke instead. And in general, they've done really well, but neonates tend to do well regardless, so it's hard to say for sure.
What's HIE?
HIE, hypoxic ischemic encephalopathy.
Got it. What about kids after cardiac arrest? Are they cooled?
So so we have pretty good data out now. So they are temperature managed. They're not aggressively cooled, but they are aggressively temperature managed. So there was a pretty big trial recently called the THAPCA trial that looked at both in-hospital and out-hospital cardiac arrests, and cooling, hypothermia didn't do anything, but targeted temperature management was definitely beneficial.
I'm just pulling up your email super fast, and I'll put it in the box.
Yeah, no problem. It's just rfelling@jhmi.edu. I suppose I could have just said it and then people would have it.
That's good. Perfect.
Somebody asked, define the difference. So stroke is a blood clot to, essentially it's a focal injury. So one blood vessel is affected. Hypoxic ischemic encephalopathy is what you might think of as after cardiac arrest, for example, but in neonates, it's typically results from birth asphyxia, which it's not the preferred term anymore, but that's the best way to describe it. So reduction of, so more global injury of the entire brain compared to stroke, which is a focal injury of one part of the brain.
I think he was asking about the difference between cooling versus temperature management.
Oh, whoops, sorry about that. So cooling was, I forget what the exact numbers that they used, but I want to say they cooled to 32 degrees maybe, or 34 degrees.
I'm going to say 33, but yeah.
Yeah. And targeted temperature management looks at more like 34 to 36. So kind of gentle cooling, just making sure that they're certainly not becoming febrile or hyperthermic is the important thing.
Oh, can someone bring us new information on concussions in children? They want to invite you back to talk about concussions in children.
You could do that. I actually, so, my other hobby is I work in the brain injury clinic at Kennedy Krieger Institute, and as part of that, we are kind of the concussion clinic as well.
That's great.
I'm not as much of an expert in that area, but becoming one pretty quickly. So if I can't do it, I certainly know some other people who would be happy to.
Thanks. I think that's all we had, Dr. Felling.
Okay.
I think that's about it. so far. Anyone else, you guys? Super informative, great idea. Thank you. Yeah, I
Well,
think
thanks
that's it.
for everyone who attended. I appreciate it.
Thank you so much. Have a great evening and stay safe and enjoy the time with the kids.
Yep, and you know, don't hesitate to reach out by my email. I'm happy to chat with you guys if you have additional questions or